The kidneys participate in urinary elimination by filtering waste and balancing fluids, electrolytes, acids, and bases. Any problem that disrupts kidney function limits the ability to meet that need and has the potential to impair general homeostasis. After this lesson, you will be able to use laboratory data and clinical manifestations to determine the effectiveness of therapy for pyelonephritis. Describe the clinical manifestations of hydronephrosis. Explain the relationship between hypertension and kidney disease. Coordinate nursing care for the patient with renal disorders. And coordinate nursing care for the patient during the first 24 hours after a nephrectomy. The kidneys work together with many other organ systems. Thus, kidney disorders affect systemic health and can lead to life-threatening outcomes. Kidney disorders are classified as congenital, obstructive, infectious, glomerular, or degenerative. Our first disorder we will discuss is polycystic kidney disease, an inherited disorder. These are fluid-filled cysts that develop in the nephrons. These cysts damage the glomerular and tubular membranes. The kidney will enlarge 2 to 3 times its normal size. There will be increased renal output, possibility infections, rupture, and bleeding. Renin may be activated, which causes hypertension. The genetic part of it is believed to be either recessive or dominant. Clinical manifestations includes abdominal and flank pain, hypertension, nocturia, increased abdominal girth, constipation, bloody or cloudy urine, and/or development of kidney stones. Diagnostic testing will include renal sonography, which is less risk to the patient, a CT, or an MRI. Collaborative care will include Septra or Bactrim or Cipro for infections, to apply dry heat to the abdomen. We'll check blood pressure readings. Diuretics may be added. ACE inhibitors will decrease microalbuminuria. We will do daily weights and provide low sodium diets. Our next kidney disorder we're going to discuss is obstructive disorders. Hydronephrosis and hydroureter causes urine outflow obstruction. It may be secondary to tumors, stones, congenital structural defects, or fibrosis. We'll need urologic interventions such as a cystoscope. Nephrostomy will be the line of treatment unless the obstruction is resolved. Prompt recognition and treatment are crucial to prevent permanent kidney damage. Other renal problems include acute pyelonephritis, chronic pyelonephritis, or abscesses. Acute pyelonephritis is an active bacterial infection that is associated either with pregnancy, obstruction, or reflux. Clinical manifestations will be fever, chills, tachycardia or tachypnea, flank back pain, CVA tenderness, nausea or vomiting, malaise or fatigue, or nocturia. Chronic pyelonephritis is associated with repeated UTIs and generally also associated with structural deformity. Clinical manifestations include hypertension, the inability to conserve sodium, the inability to concentrate urine, hyperkalemia, or acidosis. Abscesses are pockets of infection. These pockets of infection are generally filled with pus. They can be located anywhere in the kidney. This runs into scattered infection throughout the kidney. There will be inflammation, scar tissue buildup, and the possibility of fibrosis occurring. The surgical procedures include pyelolithotomy, stone removal of the kidney, nephrectomy, removal of the kidney, uretroplasty, which is ureter repair or revision. Now we will discuss immunological renal disorders. There is glomerulonephritis, and signs and symptoms include proteinuria, hematuria, decreased glomerular filtration, edema, and hypertension. There's a collection of the immune complexes in the glomeruli, and recall that the immune complexes are antibody reactions with the antigens. Acute glomerular nephritis follows an acute infection. One of the common causes that has been associated is systemic lupus erythematosus. 75% of cases present with edema or hypertension. You want to check the patient's breathing ability. They may have exertional dyspnea or orthopnea. Check for neck vein distension. Check for microscopic hematuria. It is often easily confused with CHF. Chronic glomerular nephritis usually occurs over a time span of 20 to 30 years. The kidney atrophies. There will be mild proteinuria and hematuria. Hypertension and edema are only the manifestations generally seen. Renal failure follows with mental status changes. Collaborative care will include lab diagnostics. There will be hematuria and proteinuria, and it's usually seen in early morning specimens. The GFR will be decreased and the BUN will be increased. Nursing interventions will include antibiotics, diuretics, antihypertensives, potassium and protein diet restrictions. Dialysis may be needed, and then there is also the possibility of plasmapheresis. Chronic glomerulonephritis will include uremic symptoms such as slurred speech, ataxia, tremor, or asterixis, and the ability to maintain a fixed position with the arms extended and the wrist hyperextended. Diagnostic features will include proteinuria, red blood cells, the GFR is low, serum creatinine is high along with the BUN. They will retain sodium and potassium and phosphate, and acidosis may develop. Now we are going to discuss nephrotic syndrome. So what is nephrotic syndrome? This is when there's an increased glomerular permeability. It allows larger molecules to pass through the membrane into the urine. A defect in the glomerular filtration known as Fabry disease, a genetic cause, is one reason for nephrotic syndrome. Otherwise, it can be immune problems or inflammatory processes. There will be a massive loss of protein into the urine. ACE inhibitors can be used to decrease the protein loss. Steroids or cytotoxic agents will be used if it's an immunological cause. Heparin may also reduce protein loss. There will be sodium restriction, and diuretics can be used to also reduce edema. For the dietary aspect, You have to look at the glomerular filtration rate. If it's okay, then the patient may have protein. If it's low, then we need to decrease and provide low protein diet. We will also assess for hydration status. Vascular dehydration is common. Problems can arise in the kidney tissues around the nephrons as well as in the nephron tissues, and these are usually caused by immune problems. There also is degenerative disorders that change kidney function that often occur with a multi-system disorder. These degenerative disorders can be nephrosclerosis, renal vascular disease, and diabetic nephropathy. Nephrosclerosis is a thickening in the nephron blood vessels resulting in narrowing of the vessel lumen. This occurs with all types of hypertension. It is seen after the blood pressure readings are greater than 160/110. Hypertension is second leading cause of end-stage renal disease. Treatment is usually ACE inhibitors. Renal vascular disease is a severe narrowing of the lumen of renal arteries, reducing the blood flow to the kidney tissues. There is a sudden onset of hypertension. Atherosclerosis or blood vessel hyperplasia could be the main cause. There will be elevated serum creatinine with decreased creatinine clearance. There will also be signs and symptoms of poorly controlled diabetes or sustained hyperglycemia that will occur. Then we have diabetic nephropathy. Diabetes mellitus is the leading cause of end-stage renal disease. It is related to the extent and the duration of the disease. First symptom is proteinuria. There could be retinal changes that tend to occur about the same time. As renal function deteriorates, hypoglycemia may occur due to the inability to excrete insulin, so it remains in the system longer, and the patient thinks they're actually improving. Now we're going to move on to renal cell carcinoma. In renal cell carcinoma, there are alterations in the erythropoietin causing anemia or erythrocytosis. There will be renin alterations causing hypertension. The parathyroid hormone that is produced by tumor cells may actually cause hypercalcemia. The increased human chorionic gonadotropin levels will cause decreased libido. There are 4 different stages of renal cell carcinoma. Stage 1. Tumors are up to 2.5 centimeters and they are within the capsule. Stage 2 is greater than 2.5 centimeters and extends beyond the capsule. Stage 3 is involvement into the renal vein and or the lymph nodes. Stage 4 is an invasion of adjacent organs. Some risk factors for renal cell carcinoma are tobacco or exposure to lead, phosphate, and or cadmium. Nursing interventions will include a nephrectomy. Remember, tumors are highly vascular, so there will be concerns about bleeding. Post-op, we will assess renal functions by hourly urines. We will check for hemorrhage and adrenal insufficiency. There will be a risk of atelectasis. There will be antibiotic coverage too. Okay, let's discuss renal trauma. During renal trauma, bleeding is the primary problem. We want to check vital signs and evaluate flank areas for asymmetry. The abdominal assessment will be osculation and percuss the abdomen, and then inspect the urethra for gross bleeding. Urinalysis may show red blood cells. We will need a CT scan at this point. Interventions will include dopamine to promote renal perfusion, clotting factors like vitamin K, provide platelets if they're needed, and then give fluid therapy, and possibly even pack red blood cells. Surgery may be needed, which would include a nephrectomy. There's such a thing as bin surgery. The kidney's taken outside and vessels are repaired and then is placed back inside the body. Post-op, we're going to check for urine output such as color, clarity, amount, and frequency. And then we're going to educate the patient signs and symptoms of UTI such as chills, fever, lethargy, cloudy or foul-smelling urine. This concludes the lesson of the interventions for clients with renal problems. If you have any questions related to the content of this lesson, contact the instructor.